we have Dick Stewart here to talk to us a little bit for the ABCT CBT Pioneer Series. So take it away.
So thank you for giving me a chance to share my history with behavior therapy and with ABCT. This feels a little like a self-delivered obituary, but I will do my best to keep it short. I plan to move from the personal through the organizational to the societal level, and I'm going to conclude with 3 recommendations. Now, I begin with personal because, as Monty in his wonderful personality text Beneath the Mask has shown, mental health professionals base their theories primarily on their own life experiences, and the theory becomes a metaphor or reconceptualization of how they view their own lives. As you'll see, this is profoundly true for me. I was born in 1933, which, as you will see, turned out to be a good thing. I grew up in a dysfunctional family that left me very insecure and prone to excessive, reflexive, emotional reactions, some strong highs, but many more lows. So that taught me to be wary of parents. When I was a toddler, my parents tied my left hand behind my back because they believed that lefties would have a hard time in life. This probably contributed to the profound dyslexia and dysgraphia that I still experience today. At the time, these labels didn't exist. So problems like mine were attributed to, he's lazy and should try harder by teachers. So this added school to home in my list of punishing environment. I was admitted in college in 1951 because the World War II vets had used up their GI Bill benefits and had come and gone, and colleges would take anyone with a pulse. In fact, I had to sign to get a high school diploma. I had to sign a letter agreeing not to apply to college because the high school didn't want to be embarrassed by my underperformance. I did poorly. The one psych course I took, I hated. And I basically wasted the first 3 years of college having learned nothing. But at the end of my junior year, one of my part-time jobs was catering poetry readings. And I replayed a test tape, and I realized that I was not tracking the final letters of words, and I was also doing some letter reversals. And I figured if I'm doing that to letters, I'm probably doing it to numbers as well. In fact, I still do that. And so taking down phone numbers from my answering machine is a real crapshoot. And I never know who I'm going to call back. Um, um, the first test I passed basically was the LSAT after I learned how to compensate for my mistakes. At the time, the LSAT was a logic test, and I had survived the first 20 years of my life solely on the basis of logic. I started law school and liked it, but I was drafted early on because deferments were based on undergraduate grade point at the end of the Korean War, and mine was abysmal. I was assigned to infantry basic training in Fort Bliss and managed to sneak off base in order to be able to get a job as an instructor teaching an intro economics class at University of Texas, El Paso. Thanks to a perk, I was able to take other classes tuition free, and the only 2 that were available on the day that I taught were 2 psych courses. I liked them enough so that after I was discharged and got back to New York, I enrolled in a psych and social work program instead of law. Clinical psych in New York in the late 50s and early 60s was completely dominated by psychoanalysis. which was the core of my training, and I was a committed analyst. I kind of loved the role. Uh, my first major teaching job was at University of Michigan, and I went with a strong psychodynamic orientation, believing that nobody who teaches therapy, that everybody who teaches therapy should be doing it. I started a small private practice in which my first 3 patients forced me to realize that psychoanalysis had little to offer the people who were facing real world challenges and needing rapid change. The first was a woman I'll call Gloria. She threatened suicide if she didn't lose weight. I said, please don't commit suicide. I can't have my first patient in Ann Arbor be a suicide. But she said, I'm really serious about it. So I searched the psychoanalytic literature and learned that obesity was a vestige of early psychosexual trauma, insight into which would do nothing to help her shed alien pounds. The second patient was a boy I'll call Roy. He had been in a very expensive psychodynamic day treatment program for 3 years because of a food fetish and academic failure. Again, psychoanalysis had nothing to offer him. The third patient was a girl named Debbie, who had attempted suicide by actually slicing her brachial artery. Um, and it was an accident that she was still alive. She felt life was pointless because she saw no possible ways to get any kind of satisfaction. So nothing that I learned in grad school helped with any of these patients. But I couldn't just dump them. So I did what I later learned Fred Skinner advised all of his trainees to do. I listened to them and tried to understand their behavior in light of the context in which it occurred. Ironically, um, uh, I received 2 unrequested desk copies of collections of readings edited by Len Ullman and Len Krasner and Ullman. And they summarized what was known at the time about behavior modification, which as a psychoanalyst, I considered to be real anathema. But I read them and they really suggested some viable options. So abetted by 4 colleagues at the University of Michigan, Eileen Gambrell, Sheldon Rose, Jim McConnell, and Tony Tripodi, my thinking made a very sharp U-turn. And I began to think of myself more as a behaviorist. Um, what was wrong with Gloria, I learned, was that she overate because she used food to control moods, essentially to combat loneliness and depression. That became obvious when I asked her to record not just what she ate, but when she ate it and what she was feeling at the time. Going back to Monty, I had used retreat into fantasy and dissociation to cope with my troubling times, just as Gloria was using food to control with hers. Roy, it turned out, was not psychiatrically impaired. He had typical teenage food fetishes, and he was dyslexic. Guess what? Very similar to my experience. And Debbie's hypercritical older parents and inflexible school seem much better explanations of her suicide attempt than any resulting personal patterns. And again, it closely matched my early life experiences. So psychoanalysis had nothing to offer these fine people, pragmatics did. And that sealed my transition to behaviorism. I published fairly early some papers on the management of overeating and then Slim Chance in a Fat World. Trick or Treatment, which summarized the intervention I did with Roy, and papers on behavioral contracting, which was the method I came up with to help Debbie. That led to a glimmer of notoriety, just enough to allow me to be accepted by a small group of rebels who used to meet in a backwater of APA, and they were the early founders of AABT. My involvement with AABT, which began more than 50 years ago, uh, I still remember with immense joy. The 10 years that followed were by far the happiest and most productive of my professional life. The association at the time was really important because it was the way for early behaviorists who were working in small uh, pockets around the country to come together for mutual stimulation, and it provided an outlet for describing methods and outcomes and getting valuable feedback and suggestions. At the time, AABT had just a few hundred members. The leading lights in the organization were Joe Volpe, Joe Cortella, Len Ullman, Jerry Davison, Jerry Patterson, and some not so well remembered people like Herb Fensterheim and Andy Salter. Everyone was more than welcoming. They in turn provided links to a group of other people like the Kansas group, Mont Wolf, Todd Risley, Jim Sherman, Og Lindsley, and Nate Asburn, some of whom eventually played key roles in the development of AABT. The path also led me to Fred Skinner, who, like others, offered unexpected friendship, guidance, and encouragement to someone with no formal training in behavior therapy. So I truly was reborn. We all shared enthusiasm for promoting a pragmatic basis of intervention, despite palpable internal tensions within ABT between the respondent and the operant conditioning groups. I was a member for a few years before being elected to the board. I co-chaired the program committee with Bob Limmerman, and the two of us were able to transform annual meetings from lost leaders to revenue sources. I was president-elect in 1975. At that time, AABT files were stored in a shoebox on the floor of Dorothy Suskin's closet. Working with Jerry Davison, we reorganized the association membership, which was growing enough to allow us to hire our first full-time exec, who was Betsy Kovacs. Also, Jerry and I, along with Stephanie Stoltz, co-authored the first code of ethics for AABT. And finally, we negotiated a new publisher for behavior therapy, whose growth was being thwarted, we felt, by the way it was being handled. Shortly after my past presidential term ended, I decided to step aside. I was reluctant to leave the organization because it was so gratifying, but I felt as long as I stayed, I was going to stifle the involvement of younger people who had fresher and different ideas. The association grew rapidly, perhaps because I left, and you are well aware of how large and influential it has become today. So that's the end of the self-aggrandizement. I'm not going to bore you with a recitation of my efforts in our field, which frankly, I think pale in comparison with the achievements of presidents who precede and followed me. So I'll use my remaining time to highlight three themes that I think have implications for the future of behavior modification. The first one is that behavior is multiply determined, so excluding any attention to potentially verifiable dimension could limit the prospect for future outcomes. While some suggest that behavior therapy should be purist, I advocate an integrative approach. Early in the evolution of behavior therapy, many of us overstated our opposition to the role of history. and the impact of individual characteristics, although we took learning history very seriously. I was thrilled by that because behavior therapy promised to liberate me from the shadow of a pretty troubled childhood. As we evolved, we also didn't pay much attention to cognition and little attention to neuroplasticity, which at the time was really in its infancy. We now appreciate the necessity of including these and other valuable perspectives. I think we need succinct summaries of our inclusive logic. I keep mine to one page, which you can see in the theory model. Uh, uh, as is clear, I believe that predisposition begins with temperament. When I stood at the foot of the delivery table and watched my kids, the birth of my kids, it was pretty clear from the way they initially reacted that one was going to be curious, one was going to be sort of irritated, and one was going to be very happy. Temperament creates an enduring predisposition. It interacts with early life experience to create internal working models. When I ask patients to tell me the 2 or 3 things they think that best define what they, as how they remember their childhood experiences, often the themes become very, very clear and recurrent. So they create the predisposition to respond to the world in individual ways. So together, temperament and internal working models create the foundation for the potentiation level, the first step of which is emotional regulation. People who have mental health problems almost invariably react too quickly, too strongly, and get into trouble because of it. Now, I certainly did. So the first step is to help them learn to slow down their reactions long enough so that they can think much more clearly. So they have to have cognitive flexibility. If you talk to emotionally dysregulated patients, they will tell you, well, there's only one way for things to go. Fact is, things can go in multiple ways, but you have to be open to conceptualize the possibility. So the second aspect of the training that I do trains people in how to think much more flexibly and creatively about the possibility of solutions. The third dimension is both emotional regulation and cognitive flexibility create the options to interact differently with people. And the experiences we have with other people reinforce the way that we function. A lot of people with behavioral difficulties are very inflexible in their perception of others, and they don't learn from their experience. So training in social awareness is a third dimension of the potentiation that I do. Uh, Training people in the skill sets in those 3 core dimensions then allows them to change what they do in the real world and create different kinds of opportunities to elicit different kinds of experiences. Relating it personally, when I was an analyst, I talked only to analysts and saw very few alternatives. When I became a behaviorist, I started thinking like a behaviorist. The experiences in the world really shaped my core beliefs. So what I consider the function of therapy to be is to equip people to have experiences in the real world, and that's the elicitation level of my theory, that allows them to actualize their goals to be the kind of person that they want to be. So this is a much broader conception than I ever had when I was an analyst, where everything was related to early psychosexual development. So a few caveats. First, theory is a useful source of hypotheses, but pragmatics have to guide the choice of additions to our approach. Um, uh, it's important to add things that expand or deepen the scope of the model if they can be described and measured objectively, and if in practice they yield better proximate outcomes and more sustainable long-term results. For example, as I said, internal working models greatly enhance my understanding of patients' motivations, help me identify recurrent themes and barriers to change, and facilitates decisions about the elements of a better life. So please think integratively and broadly and be open to evolving new kinds of um, core information. Second, it went what may be a revolutionary but often unnoticed change. Behavior therapy is an inherently collaborative model, which contrasts very, very sharply with therapist-dominated psychoanalytic therapy, and even things like transaction analysis and uh, and similar kinds of approaches that vied with psychoanalysis, because the therapist was always characterized as the judge who revealed to the patient what the patient was doing right or wrong. At the beginning, we railed against the psychoanalysts who treated their patients like pawns. When I was trained as an analyst, if a patient wanted to read an article that I had read, we diagnosed that as identification with the aggressor and criticize the patient for doing it. At the same time, they accuse behaviorists of being mechanistic and manipulative. Well, there was some truth to that accusation. For example, the public media saw things like Clockwork Orange, in which aversive conditioning, as you remember, was used to control homosexual impulses. Um, uh, it was very important, I realized, not to tell patients what to do, but to negotiate with them solutions that they agreed could have some possibility. So at the highest level, we practice now principle-driven intervention. I share my therapy model with patients early in the process. Again, it's nice to have it in one page, so we can discuss and customize the logic of the work we're going to do together. Uh, uh, in my model, I rely very heavily on goal attainment scale. We negotiate what to do and figure out the steps to get there, and that becomes a measure of success. So it's important to remember that categorical diagnosis doesn't really effectively inform intervention. If I know that a patient is diagnosed as schizophrenic, that tells me that his judgment or her judgment may be flawed in some way, but it doesn't tell me exactly what he or she does and what changes are necessary. So I think it's much more important to use dimensional assessment rather than categorical assessment. And as you know, the vaunted DSMs are actually the product of a small group of people who negotiated the way they wanted to define disorders in order to get reimbursed by insurance companies. So, so I think it's very important to do diagnosis only when it's necessary for reimbursement purposes, but to base therapy on dimensional assessment. Also, it's important to take the literature with a grain of salt. We can't use nomothetic group data as a basis for predicting idiographic or individual outcomes. So I think it's important to treat all intervention as a series of N of 1 experiments in which you test hypotheses based on the literature but refined in order to calibrate well with the patient that you're seeing. The third thing is that although there are some noteworthy exceptions, behavior therapy has always essentially focused on intervention with individuals, whether done in groups or singly. But behavioral health needs far exceed the capacities of individual intervention. Therefore, it's time to invest much greater effort in systemic community-focused programs. Fred Skinner's Walden 2 is a Bible for me. It's the ultimate utopian model of how to design a society in a manner that fosters the kinds of interactions consistent with community values. It's long been in the background of our thinking, but now it's being brought forward by, again, seminal leaders like Al Kasten. Expanding the practice model to, I think, will be necessary. In order to expand the practice model, it'll be necessary to forge closer links with primary care, emergency department, pediatric, and geriatric physicians who could dramatically increase the reach of behavioral health services. Doing so is going to require a number of changes. We'll need new practice protocols, new models for interprofessional collaboration, new interdisciplinary training programs. We'll need new programs at the pre and postgraduate level, new license and certification pathways, and new reimbursement formulas. In particular, I think it's really important to focus on the aging population because it will soon be the majority. And people like me are going to need the help of young folks like you who are going to come up with creative solutions to the problems that we will deny but inevitably face. So all three of these steps come at minimum cost compared to the much greater social cost of the perpetuation of intergenerational gross social maladjustment. So I've taken enough of your time and pontificated enough. Thanks so much for listening this far. And if you have any reactions to anything that I've said, I would love to hear from you, because for me, this is a never-ending process in which my core theory will change about every 6 months as I learn new things. I'd love to hear about some of those new ideas from you. So thanks a lot and have a wonderful time as in behavior therapy.